Yeah.
Okay, guys. So we can discuss this one. So thing is, in a clinical station, short stature is very common, and most likely, the case, the opening statement will be like, examine this child generally, or mother is complaining the child is not growing well, or maybe the short stature is there. Okay, so this kind of opening statement will be there. So there is no definite actually approach that in a like cardiovascular, maybe respiratory, or maybe CNS, not like that. Most of the thing is general examination, most of it, because we need to pick up the clinical science, and some of the areas we need to measure something. Okay, so that is basically the approach. Now we already discussed what may be the other cases, the list of cases. Now, as we discussed, this area in this short stature, two important areas. Number one, growth chart. Number two, puberty. And as usual in every station, this we need to comment on this, but clinically, most of the short stature cases, there may be some of the finding with pivotal delay, maybe, or maybe precocious puberty. And definitely the short stature will be done. They sometimes ask to plot the height and weight and tell the finding, after that the examination. So these are the part. So overall start, as we all know, after entering the room, we will take the permission of the examiner. At the same time, we need to just take the permission of maybe the child, but here we need to be very careful. Why? Suppose if the child is like 15-year-old, or maybe 12, 14 or 12, anyway, girl child, and very short. So we need to behave like little, they are not all the child is IQ is low. So we need to behave like little of adult manner, not like child. Okay. So they look like maybe they look like child, but we need to talk to them just like little, like mature. Okay. Now the thing is, general observation we need to start after introducing and taking permission and washing the hand. So as a general rule, we are using the nomenclature of wipe. That is hand washing, introduction, then permission, then exposure. So exposure here sometimes is a little difficult for like in a little older age group of children. But as much as possible to see the finding, even we can take the permission of the examiner. And what are the examinations? All we know that 4D NS, okay? 4D, that is device, dysmorphism, and can anyone suggest? Sorry?
Dimension, disease, distress, dysmorphism, surroundings.
Excellent. So we all know these are we need to follow. Just after entering the station, we need to ask the permission. After that, whenever we have a look at the child, that is called screening, just like a computer. Okay, so screen the child, whether the child is short as per age, because age will be just provided that this child is 12 years old girl, name is blah blah blah, and please examine this child. So according to the age, we need to think whether the child is short or tall, or maybe any dysmorphism. So that is called screening, just after entering the room. And at the same time, if there are various, like we will discuss one by one everything. But before that, we need to keep in our mind what are the common scenario that is usually given in the exam. So dysmorphic faces according to the syndrome. Okay. or may not be with associated syndrome, but we need to be familiar with the phases, dysmorphism. So maybe Turner, maybe Noonan, maybe Russell Silver, maybe many things, Downs even, or some other syndrome also. And now at the same time, growth. So growth, definitely we need to see whether the child growth is short, maybe short with thin build, or maybe the child is obese. So here is some of the clue that if the child is short and obese, definitely some of the endocrine problem we will suspect. This is the most common association. And if the child is short and thin, then we can suspect the other findings associated with this kind of children. Okay. Now, if they are classified, dysmorphic like short stature and non-dysmorphic short stature. We will go into that part later on. But if this is the general approach, actually, just to introduce you. So have a look in this, different type of phases we can face in the exam. Okay. That is not I have just put this, given this one just for just finding when after entering the room, maybe different type of like maybe one of them. Now the measurement part, that is we can keep it for the at the like measurement can be we can keep it like the end of our examination, because this is little time taking. Okay, so I think it's better to discuss at the end. Okay, we will discuss this part at the end. Now, after this, there are few of the maneuvers that will differentiate the clinically. The child is, suppose if this is some of the syndrome, then what will be the finding in maneuvers? So in maneuvers, they say that inspect from the front. So in the front view, what are the thing we need to see? That is asymmetry. So if there is any asymmetry of the body, including the limbs, that may be present with, all we know, Russell Silver, and another hemihypertrophy may be there. Can anybody tell the name of this another? No,
Bequeathment.
Excellent. So that can be also. So not short stature, but sometimes hemihypertrophy. Now, at the same time, from the front, we can observe the carrying angle also. So we need to ask the child, hold the arm by the side with the palm forward. So we need to observe actually the carrying angle. So carrying where the carrying angle is increased. That is
Turner syndrome.
Yeah, Turner, either Noonan also sometimes. Okay. Now, some of the restriction of elbow joint sometimes present with achondroplasia or achondroplasia because of contracture. They are very common in this skeletal dysplasia also. Maneuver 3 is short limb. Okay. Now, for the upper limb, there is various type of shortening. Okay. So short stature with shortening of the limb. And that is very important. Few of the syndrome which are very characteristic shortening in different parts, like not definitely achondroplasia, but not only achondroplasia. Here is the importance of clinicals. Okay, so I will show you a picture. Please kindly have a look over this one. So not only achondroplasia, limb. This first picture, that is a normal hand. Okay, that is humerus and radioulnar length. These are mostly equally distributed, near about. But if there is rhizomelic shortening, that is mostly present in achondroplasia, here look at the humerus. That is very, very short. Okay. This type of shortening is present in achondroplasia. Now, The hand, again, if you find some of the shortening, but the shortening not in humerus, that is present in radio ulna, this part, that is called mesomelic shortening. Okay. Now again, this part, acromelia, this acromelic shortening, where the humerus near normal, radioulnas, these are also normal, but shortening on the limbs and the like phalanges. Sorry. So this area, the thumb, like fingers and all over this hand is shortened. That is called acromelia. And another variety is there, that is everywhere shortened. That is short humerus, short radioulna, as well as this part. So this is called micromelia. Okay, so these varieties of shortening may be there. And according to this variety, we can even identify what may be the syndrome. Okay, the case. Now what happened? Basically, we need to assess clinically. This kind of shortening is there or not. Now I am opening my camera. So first maneuver, where in the maneuver 3, there is short limbs, basically the upper limb. We need to check. Okay, if now ask the child, just have a look on the camera, ask the child to make like this. Okay, have a movement like this, both the side. Now normally these two radius and ulna as well as this humerus usually equals, that this hand is not overshooting. So if there is the rhizomelic shortening, that is this part, humerus is short, this hand will overshoot. Okay, so that will confirm that is the type of humeral shortening, which is called rhizomelic shortening. So this just suggest the child may have achondroplasia. Okay, this kind of finding is present in achondroplasia. Now, if there is mesomelic shortening, that is that this part, that humerus is, whenever the child is doing that, at the same time we can find out whether this rhizomelic shortening is there or mesomelic shortening is there. So if this hand is not reaching up to this shoulder only, then only radioulnar shortening is there. So here we can identify that is mesomelic shortening, that is present in Ellis Van Buvel syndrome. Okay. Now distal segment shortening, that we just have seen the bones. That maybe humerus and ulnar radioulnar distance, I mean the length is normal, but hands and fingers over this area is short. So that is sometimes from acromelic dysplasia. Acromesomelic dysplasia. Something. And another variety is there, that is non-rhizomelic, mesomelic short arm and trunk. That is present usually in hypochondroplasia as well as mucopolysaccharidosis or GM1 granulocytosis. Okay. So this maneuver 3, if you ask the child to do like this, you will find the finding according to the syndrome. Okay. Now we are moving for the next part, maneuver 4, which is examination. Very easy. We need to see the hand basically very carefully, very carefully. So if there is Down syndrome, there will be, if ask the child to show the palm actually, just like this. Okay. So whenever we are asking the child, we can see if there is a single palmar crease or not. So that will have a suspicion that this, okay, Down syndrome we can definitely identify over the like entering the situation maybe. So we need to find out the clinical findings. So simian crease, single palmar crease may be there. Sometimes clinodactyly in Russell Silva syndrome, short fingers like hypochondroplasia maybe. polydactyly, Ellis-Van Crevers syndrome again, Lawrence-Moon sometimes, syndactyly in upper, we discussed, and joint contracture as well as scars. Okay, sometimes may be there. In which condition? Can anybody suggest?
Arthrokyphosis. Arthrokyphosis.
Yeah, definitely that will be, like arthrokyphosis. But in short stature scenario, what may be the short stitches? Arthrokyphosis childs will be mostly unable to walk because they will be mostly,
Osteogenesis imperfecta.
Mucopolysaccharidosis.
yes, yeah. If in a short stature, most commonly joint contracture and scars. Sometimes in mucopolysaccharidosis they can have even carpal tunnel syndrome. Some of the tendon release surgery sometimes they can have because of this contraction. Okay, this was there. Arthrokyphosis definitely all type of contracture will be there. All joints will be involved, but they are mostly wheelchair bound or mostly will be in a like within the bed. So
How about
again,
osteogenesis imperfecta? Osteogenesis imperfecta.
yeah, possible, but there will be prominent like bony finding, just like excessive repeated fracture, there will be curvature of the bone as well as some of the like finding in the like sclera, blue sclera sometimes will be there with this contracture. Maybe you are right, Dr. Raj. I'm not like you are right, but very unlikely that in short stature. I mean, may or may not be. I'm not sure. That's why I'm not, speaking so much of confidently. But possible, yes. As you said, that is also possible. But most likely, this mucopolysaccharidosis is, sometimes given in the exam, and if we miss any kind of scar and contracture, that may be, like negatively marked. That's why we need to keep in our mind that mucopolysaccharidosis cases, there may be contraction as well as scar. Okay. Now, in this picture, again, I have included, I am just trying to enlarge this one. Just a minute. So here you can see different type of hand finding actually. Some this this one actually, I think some
Divided into two.
yeah.
I think.
Let me cut it out and paste one more time. Oh, okay, it's very small actually. You can, it's difficult to see. So what happened here is the different type of hand clinical feature finding. So if there is shortening of the fourth metacarpal, maybe we can suspect, or maybe with this Turner syndrome, that is also another clinical finding. If this is a trident hand in this last second from the, I'm just pointing out, very small actually.
Make it big now, Pranav.
I'm trying to make it big, but it's not happening here. Okay, so this one is Turner, and if there is any features just like trident hand, you can search over the net trident hand. Then some of the trident hands will be featured. Okay, I'm opening the camera. That will be better. So if this trident hand, then this will be the just like that. So here is thumb, the middle two finger will be very close, and last two finger will be little gap will be there. So this will be the trident finger, trident hand actually. Okay, this is the finding of achondroplasia. Okay, at the same time, and if there is sometimes if this is a small baby, small children, then they can have some of swelling that is conclusive of some of the Turner syndrome as well. If Turner syndrome is there, some of the nail hypoplasia may be at the same time there. And if there is like or Brown syndrome, then some of single palmar keys may be there. Okay, so all this finding we need to read and find out during our clinical examination what is correlating with the syndrome or maybe the disease or maybe the case given over there. Okay, so this is basically the thing. Now we can find easily, okay, if this is polydactyly, sometimes short fingers hypochondroplasia mostly, polydactyly sometimes Ellis Van or curved Lawrence moon sometimes, syndactyly we all know that is upper, yeah, and curvature we discussed. Now we need to examine the hand carefully. Now maneuver 4, turn the hand over to look for some of the features like trident, as just I discussed, the trident deformity. Okay, this trident deformity, broad, short, and trident deformity, maybe we can find out over achondroplasia. And just hyperconvex nail or sometimes hypoplastic, that is significant for this Turner syndrome. Again, maneuver 4, sorry,
Can I
maneuver
add
6.
something?
Sure.
So even when you do this maneuver, not turn your hand over, you can look for Down syndrome, single palmar crease also.
Yeah, definitely. I just mentioned that. This is, I know, actually, first, let me open my camera. They are saying, first, ask the patient to just do like this, just stretch both the hand like this. So you can see the palmar surface, this surface. Okay. Now they are saying just turn over just like this. After that, nail can be seen, and at this time, if there is any shortening, all these things will be very. So these are easy. Don't take so much of just like this. Like steps. Whenever we will ask the child, just do. Can you do like this? Flex your just elbow. Say we can quickly pick up the just finding. Yes, there is rhizomelic shortening. There is like ulnar radial. There is mesomeric shortening. That will be very quick finding. And whenever we'll ask the child, can you do like this? So at the same time, we can have a quick like idea that what is the finding. So don't take so like difficult. It is very easy to find out what. Now make it. They said maneuver 4. So they just made this like this maneuver. There is no so much of like significance to make it. It's like general examination, nothing else. So there is definitely some of the finding in the upper limb. That's why they said examine like this. Okay. So whenever we ask the child, just make a fist. Then again, the fourth like metacarpal shortening will be there. And that is significant of two areas, that is in the Turner syndrome, and another is pseudo hypoparathyroidism sometimes. Okay. Now, maneuver 7, we have completed the area of upper limb. Okay, basically the short stature. Now, in the upper, like inspect from the side. So whenever we are inspecting the child from the side, then what are the findings here? So we need to see from the side, suppose the head. If there is prominent forehead, that will be seen from the side view. That is present in achondroplasia because of what? Because of what?
Hydrocephalus.
Macrocephaly.
Yeah, macrocephaly for what?
Hydrocephalus, no?
Hydrocephalus, exactly. So hydrocephalus will be there most of the children with achondroplasia, and that's why the forehead will be prominent. And basic or the flat occiput. For what? Sometimes some of the syndrome may be flat occiput with
Down syndrome.
Down syndrome mostly, and some of the other syndrome may have flat occiput.
Hypotonia.
Hypo. Sorry.
Syndromes with hypotonia will have brachycephaly, flat occiput. maybe.
Hypertonia. Hypertonia. You need to say. Hypo or hyper?
Hypo.
That is actually depends upon the case. Actually, more, and I have seen
Okay.
several cases. But if there is any kind of finding like this, then we need to correlate with the disease or maybe the syndrome. That if there is flat occiput, this is not always this Down syndrome. Some of the other syndrome maybe have this kind of finding. So we need to correlate with the other finding also. Okay. Now, proptosis, that can be seen in the side view. Side view, proptosis, the eye is bulging out or not. So that in that time we can think about craniosynostosis, like again, apart, or maybe Cruzon. Yes. Mandible, from the side view. Mandible, micrognothia. Okay. Micrognothia may be found in Pierre Robin, maybe, or anything. Anyone? Micrognothia.
In teacher calling, teacher calling.
Exactly. Teacher calling. We discussed the previous session. Teacher callings or maybe Pierre Robin. Allegedly sometimes prognosticism. This is your sometimes in achondroplasia. What does it mean? Prognosticism?
Opposite of retro, opposite of retro, prominent mandible.
Exactly. So sometimes achondroplasia. So in achondroplasia child, mid-face hypoplasia with sometimes prominent mandible. Right?
Gigantism is also seen, no? Gigantism.
In which syndrome?
I don't remember. Gigantism.
Sotos has got the gigantism.
Yes.
But I don't know short stature is there or not.
No.
It's not in short stature.
Soto is not short stature.
Prognosticism, I mean. Prognosticism.
So they will be tall.
Prognosticism.
Overgrowth.
So basically, achondroplasia child will be prominent mandible. Okay. Now fingers, that is proximal. If the fingers reaches again from the side view, okay. If the fingers of hands are reaching the proximal thighs, that is short limb. The finger reaches the knee, near the knee, that is of due to short trunk, that is spinal shortening. Yes. And again, another finding in side view, that is lordosis. That may be lordosis may be thoracic or thoracolumbar region. Look at the second picture, second man. I mean, that is in this picture. Okay, so thoracolumbar. Lordosis may be there in the back. Thoracolumbar kyphosis may be there. So these are the findings we can find out from the side view only. Okay. So in the neck, there may be, again in the side view, there may be short neck like Pupil, Noonan, and Turner also. Okay. Low posterior hairline, again Noonan and the Turner. So these are the features, actually, clinical features. Scoliosis. Now, if there is scoliosis present, now we need to ask the patient, can you bend down body or touch the floor? So we can observe whether it is disappearing or not. If this is disappearing, that is positional, otherwise structural, right? So these are the findings from the side view we can get during our examination of a short stature. Okay. Now, after this examination, I personally think that maneuver of, that is measurement, is time taking sometimes. So we can come to that area in the during the, and after doing all these things during the quick examination. Now we can ask the examiner, I want to measure the growth parameter like height and upper segment, lower segment measurement with ratio. So this can be done in a two different way. Okay. First, look at this picture. That is little, just difficult or time taking to, just ask the child to sit down and take the upper segment length, and after that can be, deducted from the total height. That will be the lower segment ratio. I mean, the measurement.
Can I say
length.
something?
Yes.
If you don't mind.
Sure.
So it is always better to take the lower segment and then subtract the height. It is much
Yes,
more.
yes, I'm coming that point. Yeah, I'm coming that point. So that is most easier in the exam, because this process, that's why I have included this picture. Okay.
One thing, I think we don't need to, you have to know how to plot or everything. But I think whenever you see the short stature, you have to make the comment on the height. Then I want to check his height. What about his upper segment, lower segment? Then the examiner will tell you the percentile or the percentile that will occur.
Yes,
in the exam.
you are right, Dr. Abhishek. You are right. Absolutely right. But we are discussing the thing in detail so that we can remember.
Yes.
Okay.
Yes, of course.
Definitely
And
no,
mid-parental height is mandatory.
in the exam, most likely examiner will never allow to measure the height and weight, because there will be no time. Only 6 minutes, like quickly will be gone. So we are just discussing the thing to remember, never to forget. Okay. So this is the important area. That's why I'm discussing. So in this measurement area, we can have a quick look on the child and measure the height quickly with, if possible, with the measuring tape. After that, we can take the lower segment measurement, that is from the anterior superior iliac spine up to the ground, that is lower segment. So suddenly we can subtract from the height to the lower segment, that will reflect the upper segment. That is very simple and quicker, right? So we will never go into this upper segment to measure the upper segment first. This will be time taking in the exam, but this is also not the wrong thing.
In the UK, sitting height is only measured because that is whenever you are touching the patient in symphysis pubis, that is what I can say. That is not a difficult way. You have to palpate the genital, what the genital, what the inguinal region. No? That's why they usually did this sitting height.
Yeah.
For patient's comfort too.
But in our setting, we won't get this kind of stadiometer, and also it is not accurate.
Okay, wait, please wait. So in the exam, most likely they will not allow us to exactly measure the measurement actually. Okay. So it's better to mention over there, I want to measure the upper segment as well as the lower segment and the total after taking the total height. So that will be enough. Okay. Now at the same time, we can also mention, I want to just check the upper segment and lower segment ratio as well as arm span. Okay. So these if possible, check the head circumference also, weight and head circumference also. So these are the verbalization. I think that will be enough, that the examiner will know that we know this area, and that is important. Okay. So now, if you again one more time see the approach, that is mostly inspector. All the finding is mostly inspectory finding. Can you actually just extract out?
Thing I want to add.
Yes.
You have to say about the mid-parental height. You have
Yeah,
to
coming. It's not over. Please,
Okay.
it's not over.
Sorry.
So there are few areas definitely. So I am talking about the clinical features in a short stature. After entering the room, the most important finding will be if we observe the child very calm way, the clinical feature will be prominent in front of us. We need to be just cool enough. Now, after all these measures and maneuvers, here is the last part, but very important. We never should miss all this last part. That is number one, they inspect the tenor staging of the child, that is pivotal part. That is also inspected finding. And precordium, as the child is, if the child is properly exposed, the precordium, some of the bulging or some of the hyperdynamic precordium or some of the chest deformity sometimes may be present. Percussion, I really don't know why they mentioned that hyperresonance chest.
I don't
That
think
is
there's any
just
need to do percussion.
no need to. But auscultation, if any precordial finding is there, then we can ask that I want to auscultate according to the case. According to the case. Suppose if the case is obesity, short height, obesity with short height, then what will be the auscultatory finding? Or you will expect the child who is obese and short. Can anybody tell? Anybody suggest?
Cushing's syndrome,
I said auscultatory finding.
hyperdynamic. Okay.
Hyperdynamic precordium.
Hyperdynamic precordium
Hyperdynamic precordium. Okay.
because of high BP.
High BP sometimes. Okay, fine. And anything more?
Obstructive
Mama.
sleep apnea, na? So, pulmonary.
Pulmonary hypertension
Pulmonary.
they'll have. Because
Pulmonary
of
hypertension. Excellent. So what will be the finding in auscultation?
Loud P2.
hyperdynamic apex.
Yeah,
And loud
exactly.
P2.
Excellent. You just reached the point. Actually, hyperdynamic apex may be with loud P2, as Dr. Rajesh said. Loud P2. Okay. So this will be the auscultatory finding sometimes if the child is. And now, if the child has some of the cardiac surgery for chronic illness, then again there may be some of the murmur also. And for this reason, the child is maybe not growing up because of this cardiac problem. Okay, so that's why, according to the case, we can include the relevant systemic examination. We need to mention, and sometimes abdominal examination. Okay, so where you will examine the child's abdomen in short stature? Can anybody suggest? Again.
Yeah.
Kidneys, maybe? Kidneys.
In case of toxicity, means steroid toxicity, where there can be both maybe hampered.
Steroid toxicity, what will be the finding in abdomen?
No, means reason for steroid toxicity. The child is on steroid for long, maybe because of liver transplantation or any other transplantation. Then there may be scar mark, or there may be mass like adrenal mass or Wilms tumor. They may be associated with syncoid, like where there is steroid maybe in excess.
Fatty liver.
Fatty liver in your in the obesity cases, right? Yes, that is another.
In mucopolysaccharidosis.
Excellent. In mucopolysaccharidosis, there may be liver enlargement, there may be spleen enlargement, as well as some of the kidney enlargement may be there in short stature. And Dr. Pankaj is also right. If the child is obese, who is taking the steroid for a long time, there will be obesity, iatrogenic obesity. Okay, again, the obesity will be associated with some of the fatty liver. as well as we can if we are examining like abdomen, we can get some of the finding like this. Even some of the abdominal stria maybe, right? In inspectory finding.
Yes.
So that is the importance of relevant systemic examination. Okay, we can include this one if that is relevant to our cases. Now, here this line again. Now, Dr. Abhishek, I'm coming to your point. The systemic examination, that is, I want to complete my examination by doing this. Without this, our station is not complete. And if we forget, definitely the examiner will deduct the mark for this incomplete examination. What are those areas? Number one, look at the parent, mid-parental height, because short stature we need to assess according to the mid-parental height. Familial short stature is very common. So we never know. So a child is short stature or not, to come to a conclusion, we always need to mention this one, mid-parental height. Okay, so very, very important points. Second, we need to plot. We need to plot the growth over the growth chart. I mean, the height and weight over the growth chart. Because apparently looking, short height is very, that may be the finding, but if we plot, that will be more accurate to, like interpret. So plotting the height and weight. Third is pivotal assessment. Never ever to forget this point. If we forget this one, this is a vast area in this short session. We will always discuss, definitely we'll discuss in the later sessions with short session of pivotal area, including the stages and early puberty, precocious puberty means, and delayed puberty. That can be associated with short stature. So pivotal area we need to always mention at the end of our examination. Okay. Now, developmental assessment. Why developmental assessment is important here? Can anybody suggest one more time?
Because some syndromes can have delayed development, like your learning disabilities.
Like
Down syndrome.
Downs, excellent. Any more?
Then
Bardet-Biedl
Maybe all
syndrome.
those
Bardet-Biedl, exactly. Russell Silver, sometimes, yes, and
Turners have.
Turners, not always. There is percentage. Yes, you are right. Who is there?
It's me.
Actually, can't see it. Okay, fine. So, Turner syndrome, most likely they are normal. They will have normal IQ, but there is little percentage, around 30, what I remember. That percentage may have low IQ. And anybody else? If we say, if I say,
What about hypothyroidism?
Hypothyroidism, you are right. If this is not diagnosed at proper time, and this is first presentation, definitely neurocognitive developmental delay will be there. You are absolutely right, but this is very unlikely. Mucopolysaccharide, Dr. Raish, exactly. So I am waiting for this one, because if our case is like mucopolysaccharidosis, some of the children may have, most of the children may have developmental delay. So we can add our management part. We can add this one in our management part. We will refer the child to developmental pediatrician for the detailed development, as well as some of the therapists. Okay. So this area is also important and valuable in short stature station. Okay. And now, not the least, this is genitalia. And what are the genital abnormality may be associated with this one, genitalia? Or maybe what are the significance of mentioning this genitalia in the short stature? Can anybody suggest?
There can be
hypogonadism sometimes, like
Prader-Willi.
Prader-Willi, and
Turner.
Turner, yeah, yes.
Hypopituitarism.
Hyperpituitarism,
Hypo.
hypopituitarism, and short stature. Yes,
Yeah.
hypopituitarism definitely, like genitalia will be short, but that is most commonly present in the neonatal age group. You are right, but
In Noonan syndrome, cryptorchidism.
yes, and
And hernias.
hernial orifices, exactly. So another important area is why this genitalia examination is important. So the examiner will definitely prevent us to examine the genitalia. There is no doubt. Okay. So the importance is, suppose the child is 14 years and having delayed puberty. So at that time, whenever we are examining the genitalia, there will be like absence of pubertal signs, pubic hair maybe, and some of the children maybe early puberty is there, like precocious puberty,
Hmm.
right?
Yeah.
Suggest me a syndrome which present with early puberty, like
McConnell.
exam cases. Yeah, exactly.
Mrcpch. Mrcpch, yeah.
That is the thing I was just waiting for. McCune-Albright. Okay, so here is some of the puberty which will be early puberty. So that is basically the importance of short stature with like informant all this area. So not only the short stature, that is related to the every other areas also that will complete our examination. That is the like aim of our discussion.
Does McCune-Albright has short stature? Sorry, I'm not sure about.
They are actually they are so okay. Listen, there will be some of the skeletal deformity now. So
Okay.
sometimes for this deformity or maybe the skeletal involvement, there may be short stature sometimes. Okay.
So what happens
So
in
I am not.
McCune-Albright is that they have precocious puberty, so they won't be short in the childhood period. They'll be tall, in fact, because of the precocity. But if they are not treated, and the final height as a adolescent child, she will become shorter than the peers. So you can't
Excellent
say.
explanation. Excellent.
Okay.
Can everybody everybody need to listen one more time. This is what I read from Mrcpch. So Neha, Dr.
what
Neha,
happens
please
is-
can you please let's say loudly so that everybody can just pick up the point, because this is really interesting.
So in any precocious puberty, be it McCune-Albright, be it because of pituitary problems, can also give rise to precocious puberty, and adrenal problems like congenital adrenal hyperplasia can also give rise to precocious puberty. Okay, because the bone age is advanced. Okay, so what happens is that because the bone age is advanced, the puberty is advanced, the height, they are very tall because their height velocity is faster because the bone age is advanced. So what happens is that they, in the childhood period, they look very tall. But because the bone age is advanced, the bones fuse faster. So when they become adolescent girls, like 13, 14-year-old, their bones are already like a 15-year-old child. And if they are not treated, they will remain short. Because the other 13-year-old children will start undergoing pubertal spurt at 13 years, but these people won't, because they've already gone through the pubertal spurt when they were 8 years old, unfortunately for them. So they will remain short.
Excellent.
Yes.
So everybody got this point? Hopefully.
Yes. Thank you.
So
Neha.
yeah. So I am just simplifying the thing. The puberty will be early, growth spur will be early, but the final height will be less. Okay, the final height will be less, and those people who is normally growing, with just little bit of, just puberty is not at that point early, so the final height will be, like greater than compared to this child. Okay, that is the thing. So I think this is where this will be our approach. So we completed this one for today. Now we will discuss the thing like cases